just to save you some space on your computer. Okay, so couple rules for our journal club. So we respect each other, we learning from each other, we open and trying to get as much as we can from this session. And today's session will be slightly different from the previous one because it's not presented by students, but by the person who already have extreme experience in clinical trials. And I would like to encourage you to ask as much question to Anya as you can, because it's tremendously important to have this guest today. So please don't be shy and ask questions. Anya, are you okay with it?
Yes, I'm completely okay. Just tell me where I can see
you
them.
Can move. Yeah. Okay. So can you move to the next slide?
Oh.
So as I said, our video is recording. We have Q&A session, but usually I try to make this meeting interactive. So we usually interrupt our presenter and ask questions if you don't understand something. So it's nothing personal. We just do this as always. Again, if it's okay with you. If not, we will keep our questions and ask them after. So up to you. So it's okay if we interrupt you and ask questions.
Yes, it's okay. I just ask to interrupt me after the end of every slide, not in the middle.
Okay, perfect. And also one more thing, after this Journal Club, we send you a very short questionnaire when we ask your experience with the Journal Club. And it's not actually a formality. It's really important because we're trying to make it productive and effective. So your feedback is extremely important. So please take time and spend a couple minutes just to provide your feedback on this session. So, and let's move to our presenter. Anya, please, your turn.
Well, I would like to introduce myself just for a few minutes. Previously, I work in clinical trials. I work as a head of medical department, previously as medical advisor at pharmaceutical company. And I was and I am responsible for planning and conducting clinical trials of late phases from 2B to the 4th. So I can say that I know a lot about designing clinical trials, and actually it doesn't matter what is the medical topic because the rules of design are the same for any topic. And please don't hesitate to contact me if you need. You see my telephone number. You can write me to WhatsApp, and I will answer you in 24 hours after you have written to me. I usually answer on WhatsApp messages, but not as soon as you write me. So we will discuss this article that Marina sent me to evaluate, and it's about acupuncture. It's a randomized trial comparing acupuncture, simulated acupuncture, and usual care for chronic low back pain. And I will not just tell you about this article, but I will make some comments of methodology of clinical trial design based on examples from this article. So I hope you have read it because I don't show you screenshots from the article except the results, but I just put here some main phrases from the article. The goal of the trial, according to investigators, was to evaluate if acupuncture is more effective than usual medical care alone, is real acupuncture more effective than simulated acupuncture, and is individualized acupuncture more effective than standardized acupuncture. Actually, this topic is rather popular, and I have seen a lot of articles on this topic when I was interested in it a few years ago. And if you read the discussion in this article, you could see some links to the previous studies. So I will repeat these goals when we need, and very important thing, I will share this presentation, so you don't need to write down what it is on the slides. Well, let's start from methods. The trial design was rather simple. Patients were randomized to 4 groups for 7 weeks of treatment with acupuncture or usual care. They were evaluated at the 8th week, then in half of the year and in 1 year. These 4 groups were standardized acupuncture, individualized acupuncture, sham acupuncture, and usual care. And all of the participants were provided a self-care book. But it's also very interesting that less than 20% of all the participants have read 1/3 probably of this book by the 8th week. And I think it's a very important point for you as a medical doctors who will ask patients to read something and they will not, just because they are human beings. Do you have any questions regarding to this slide? Well, I think no questions. So what was the design? It was parallel. I mean that 4 groups were treated in parallel. They weren't crossed. It was double blind, or even I would like to say it was triple blind, because participants were blinded. They were asked to wear eye masks and lie prone with their heads in a face cradle. It's described in the article and it's very important. Then diagnostician acupuncturists were blinded. They evaluated the participants at each visit and they prescribed treatment. And the therapist acupuncturists were also somehow blinded as they could be. They delivered their assigned treatments and they couldn't influence anyhow on this treatment. It's not the true blinding, but it's really important here. So that therapist acupuncturists don't interfere in treatment. They are just care providers. They are just, I don't know, like hands of diagnostician acupuncturists. And this trial also was controlled. The first control group was usual care. It was a control group for any acupuncture group. And the second control group was sham acupuncture, simulated one. It was a control for the real types of acupuncture, standardized and individualized. I want to move on to types of trial design. It can be parallel to the left and crossover design to the right. In parallel design, all participants are randomized to one of the groups and they get treatment and they are assessed just being in one group. So if we have, for example, 100 participants, 50 of them will get drug 1 and 50 of them will get drug 2. And it will not be changed during the trial. Even if we follow the participants for several years, they still will be in the same groups they were at the beginning. The opposite type of trial design is a crossover design. It's very common in bioequivalence studies when you compare original drug and its generic one. And each participant get both drugs in this type of trial. In the first period, it always has at least 2 periods. In the first period, participants get the first drug. In the second, they get the second drug. And on the opposite, if they started with the second one, they will get the first one in the second period. There are much more types of trial designs, but these are the basics probably, and all the other types, they are based on these two. Just it can be different kinds of mixes. It can be not 2 groups, but more groups. It can be some kind of design when we drop one of the group or more. It can be the design which has the parallel part and then crossover part, or on the contrary, before they have crossover part and then they move to parallel part. But it actually doesn't matter. It's just up to you to choose how they will be mixed if needed. The main thing about these designs is that parallel design is appropriate in 3 cases. They are listed below. It's appropriate for progressive illness when patients' parameters change over time. For example, when we have a trial in diabetes mellitus, we treat patients and they are enrolled with very poor glycemic control. And after our treatment, their glycemic control improves. And for example, in 3 months of treatment, it's not the same patients that we had at the very beginning. And it would be inappropriate to cross over this trial because we will treat another population in 3 months. Then the second time when we use parallel design is when it is unethical to stop treatment, because crossover design supposes a washout period, a period when people don't get the drug. So if treatment must be continuous, if we cannot stop it, for example, in treating thrombocytopenic purpura, when a patient will have a drop in thrombocytes if we stop treatment, we cannot cross the groups. So we must use the parallel design so that all the patients get treatment from the very beginning till the very end. And the third time when we use the parallel design is long period of endpoints evaluation. I mean, when you evaluate the endpoints, the trial outcomes, for example, in 1 year. It's no need to cross the groups because the crossover trial will last for 2 years then. And if we need not so much patients, it's faster to enroll more patients in parallel design than to cross the groups. And as for crossover, it's not very common in therapeutical trials. It's more for bioequivalence and such kind of testing. It's usually healthy volunteers and it's usually drugs with short time of half elimination, because we need this washout period at least 5 times of half elimination. So if we have 4 hours when the drug is eliminated for 50%, we need to wait for 20 hours until the drug will be given again. And it is used in therapeutical trials. It is used for stable conditions, for example, chronic pain conditions that are treated with nesteroid anti-inflammatory drugs. When a patient just get the pills, for example, for 1 week, and the patient is estimated with different outcomes, and then the patient drops these pills for several days and take another pills for another 7 days. So it's just for these short periods. Actually, this is a very important slide, and if you have questions now, I would be happy to answer.
I have a question. Does anyone have a question?
Hello, everyone. I've got a question for the previous one, for the previous slide. To be honest, I don't understand how participants could be blinded if the group who received traditional treatment didn't feel the touch of the needle, if I understand correctly.
Yes, you understood completely correctly, and it's a kind of limitation of the study that is not described in the article, but you got it completely right. The patients couldn't be blinded in terms of if they got any type of acupuncture or not. So it was not masked for this separation. Of course, patients knew if they got acupuncture or if they got only traditional treatment, but they were blinded among these three groups of acupuncture. The simulated acupuncture was very alike with a standardized one. And I will show you a bit later the difference of the regimens. But actually, I think that this blindness is only for acupuncture groups. And it's very important that the authors didn't write that the trial was blinded.
Mm-hmm.
So they did it completely true, completely correctly.
Thank you.
Yeah. So my question was about this classification of types of trial and kind of based on what illness can be used for this. I mean, so you say that progressive illness, so you divided like progressive and stable condition, right? And for me, it's kind of tricky because, for example, if I'm thinking about addiction, like what is it, stable or progressive? Because on one time of period it can be progressive and other stable. Same with diabetes and any other chronic disease which have relapse and remission. And how you can say what is progressive? Even HIV, it can be stable for several years and then extremely progressive. So how you actually divide on which by which criteria you divide it on and can decide what is progressive or stable condition?
That's a very good question, and it's really very tricky to make clear division, and it depends on the effect of the drug that we are expecting. For example, if we are expecting the very strong effect, and we are expecting that our patients will improve significantly, so it can be stable. And if we are expecting a low effect, or for example, if we are treating some kind of secondary outcomes for the patient, so it can be called stable. For example, I'm not strong enough in psychiatry and in addictions especially, but I got a case of some prostatitis syndromes. And actually, prostatitis is a progressive illness. I mean that if you treat a patient, the patient improves. If you don't treat a patient, the patient has much worse condition than before. But I could find several trials with crossover design for this condition. It's only a few of them, but they still exist. And I think that it depends on explanation of your choice. If you can explain your choice perfectly, if you can, if your reviewers believe you, if your readers believe you, so you can choose whatever you need.
Yeah, totally agree. Thank you. Because I think like every time when you're trying to have like classification, it's always exceptions, you know, and it's always
it's always case by case scenario when you need to evaluate all the things that you actually need to evaluate.
Yeah. You always need to have argument when you choose something, and here you give us example of argument.
Of course. And as for this trial, they had stable condition, they had chronic pain, but we don't know what washout period acupuncture has. I mean, how long the patient should not be treated to lose all the effects of acupuncture. And they also have chosen a very long period of endpoints evaluation, this 1 year of evaluation. And that's why it was very difficult to apply crossover design. However, they could apply it because it's a pain studies. And that's why they have chosen parallel, and they are in their rights. Then, as for blinding, I remember the comment, completely correct comment, and I want to give some theory about blinding. We have blind, double blind, triple blind, and even quadruple blind. And if you go to clinicaltrials.gov, you will find there a lot of quadruple blind trials. I'll explain. Blinded is when only study subjects are blinded. We almost don't use these kind of trials now, but it is sometimes possible. However, we don't understand the need of using this type of blinding, because to blind investigators is not so difficult. You use these randomization papers or something electronical way of randomization subjects, but sometimes it's very difficult to blind the investigator. For example, when we inject something to a person, we need to inject the drug, and we need to inject either another drug or a placebo. In academic studies, we don't meet placebo control too often because it's very difficult to make appropriate placebo. They usually use something like saline solution, this natri chlor, or I don't know, glucose or something like that. That is provided in the clinics, but actually placebo should remind the drug perfectly. And if we have some colored drug, if we have some painful drug or opalescent drug, so the saline cannot remind it. And in these situations, investigators can be blinded only if they have a special nurse who will inject these drugs. But if they are lack of people, if they are lack of money or something, I don't know, they have to inject the drugs themselves, and of course they cannot be blinded in these cases. And I suppose, but it's not completely true, but in general, I suppose that if your trial outcomes are objective, for example, laboratory tests or something like that, you can provide an open label trial without blinding of investigator, and even without blinding the subject. But so in some cases it doesn't work. I don't know why, I can't explain this, but even laboratory testings can be I don't know, they can be not appropriate in open label trials. That's why we usually speak about double blind, and when we speak about double blind, actually we usually speak about quadruple blind, because if you do any investigations, I mean MRI or computer tomography, röntgen, ultrasound investigations, echocardiography, different scales that are evaluated by physicians, all these things are subjective, because you need to put these dots on the image, you need to interpret the image, you need to interpret the scales, and that's why the person who does it should be also blinded. You cannot blind investigator and the patient and send the patient to an unmasked echocardiographist, because we are human beings, and we tend to see what we want to see. Some investigators tend to see the better outcomes, some the worse outcomes. It depends on their belief in the drug. But if we are scientists, we shouldn't speak about our beliefs. We need just make appropriate statistics, appropriate trial design, and not manipulate with beliefs or non-beliefs. And as for quadruple blind, the fourth party is biostatisticians and data managers, if they are, because, for example, in academic trials, it's usually investigators who work as data managers and biostatisticians at the same time. And you must be blinded because it's very, it's very tricky, and people want to do something better. People want to choose another statistical test. Just probably you've heard, I've heard this awful recommendation for my PhD thesis. So I see the results are tricky. So would you use just another statistical test to get the results more appropriate? And it's not an appropriate way to do science. And as for very big, as for multinational trials, it's usually data evaluating committees that evaluate some data without sponsor and without investigators. They are like people who see that everything is done in appropriate way. And there are also safety committees who evaluate data in terms of safety. It's very important for original drugs with high expected toxicity. And it can be some other people who can be also blinded or unblinded. And as I work for a sponsor, I can tell you that we have to write in the trial protocol who will be masked and who will be unmasked before we have started the trial. Do you have any questions regarding this slide?
Hello, and can you please ask a question about the previous slide, about the study design? I just wanted to ask, maybe even to specify, if in crossover study, one of the advantages is that each participant can act as its own control, and that's why you said that there may be fewer number of volunteers in the study.
Yes.
Did I get it correctly?
Yes, it's a very important advantage because intra-individual variability of parameters is always lower than between individual variability. And we need more people if you have a high variability, and that's why in any ways to reduce this parameters variability, including crossover design, are good for reducing the sample of the trial.
Okay, thank you very much.
Well, I'm going further then. As for control, also just a piece of theory, control could be placebo control, active control, and sham control that we see in this trial. Sham control is used for non-drug treatment. It's for surgery, but I don't know if it is really ethical or not to do a sham operation. I know that there are a lot of operations and sham operations in non-clinical studies, for example, in rats or in mice. But as for people, it is discussable. Then we can use it for acupuncture, of course, and for any type of physiotherapy. And probably it is also discussed that we can use it for psychotherapy. But I'm not sure that it is really possible because I cannot imagine a psychotherapist who is doing the sham therapy for a person. I don't know how can he do something like that. And as for placebo and active control, I'm totally against this statement that only placebo control is a gold standard. Of course it's not, because sometimes it's unethical to put people on placebo control. For example, again, in diabetic trials, we use placebo control only at stage 2. In a short-term trial, it lasts for 3 months only, and there are not so much people. They use either investigation drug or placebo. And then after that, the second stage 2 trial is with active control, and the third stage trial is also with active control. And it is stated in regulatory documents because it is ethical, because you cannot put the patient to placebo if you have previously got at least some data that proves efficacy of the drug. And also, for example, it's unethical to use placebo in oncology. It's unethical to use placebo in strong pain or in many conditions. So for many therapeutic conditions, you can use placebo only when you have a perfect standard therapy. And probably you have seen these studies when all the patients in all groups use some kind of standardized therapy, the gold standard, and the investigational drug is added as add-on therapy. And it's the only way you can use placebo control. And the very important point of active control, I really like active controlled trials, but the main point is that this active control should have proven efficacy. If its efficacy is established, no problem will be for the investigational drug. Do you have any questions for control? Okay. Then let's return to the article. I had too many comments, not about the article. They did 3 types of acupuncture intervention, and I can say that standardized and simulated, they are really very alike. But individualized acupuncture is a bit different. It is more points, and it was for the less time. And it's very important that if a person, a subject of the trial, has previous experience of acupuncture, he could be unmasked. Because if he got standardized acupuncture before, he must be informed that there are 4 groups in this trial, and he just or she just lying down face to the table, but understanding that something gets wrong. Something is not as usual, so probably I'm in an individualized group, that's good, and I should feel better or something like that. And so the question is, were patients really masked? I didn't find this criteria of inclusion to the study that the patient should not have any experience. And were the therapists really masked? Of course not, because the therapists doing individualized acupuncture was totally unmasked. But this is very important here that the diagnostician acupuncturists were blinded, and the therapists had just to do what they were told to do. They couldn't influence the decision. And this is the quote from the article. Participants rated the acupuncture and simulated acupuncture treatments almost identically. The diagnostician acupuncturist rated the acupuncture and simulated acupuncture groups of patients very similarly. So the authors claim that blinding was provided enough. As for endpoints, they had computer-assisted telephone interviews by interviewers masked to the treatment. Probably it's a kind of quadruple blinding, I don't know. They estimated endpoints at 8, 26, and 52nd weeks, and they had 2 primary endpoints. I will not discuss all the endpoints, I will just mention these 2. It was the back-related dysfunction, the questionnaire. Questionnaire is highly subjective. And they had symptom bothersomeness at the end of treatment. It's also a highly subjective endpoint, and that's why blinding is extremely important in this trial. So we definitely needed blinding, and unmasked therapist or interviewer could unintentionally influence subjects' feelings. And you can influence your patient's feelings and perceptions if you are, for example, more attentive to patient in a trial group than in a group of comparison, or if you express some kind of expectations And again, we are all human beings and we cannot control our emotions so perfectly. We cannot control our expressions, face expressions, and we should be also blinded. It's very difficult to provide in one clinics, for example, when you have just you and your chef and nobody more on the trial, but you should ask someone else not to tell you what the patient receives in case you make these blinded randomized trials. So are there any questions regarding blinding in this study? Marina, I can't hear you.
It's because my headphones.
Yes, that's better.
Now? Okay, sorry. I totally agree about the sentence when you say that it's highly subjective endpoints, and I totally up to using only objective endpoints, or maybe objective endpoint when it's possible, because objective give you more sense, and actually it's kind of give you more reliable information, and your beliefs can be not influential on results. But I also think that subjective questionnaire and scales can be very useful, especially when we talk about pain, which yes, we know that, for example, we can use some tests, for example, called press machine for measure pain, sensitivity, or tolerability. But I think when we talk about chronic back pain, it's very important how actually a person feels and how it's related on quality of life. And I think that these outcomes, like the measurements of these outcomes, they choose the subjective, and probably we can say that, okay, it's not perfect, probably you should use more objective ones. But I also think that subjective is sometimes give you very vulnerable information, especially they compare subjective endpoints in each time point. So they can see is a change in subjective feeling. So in this point, I think this is not like highly subjective endpoints. I mean, this is, yes, this is subjective. It's not like perfect, but it's valid, and they say that it was valid in previous study, even if it was valid in telephone administration, during the telephone administration, because of course it's the telephone administration also can change their answer on this question. So that's why I want to be kind of to say that it's okay to use this endpoint. So what do you think? Do you agree with me or not? Or
yes, I have two comments on your comment. The first one is before I forget it. The first one is about the telephone contacts. Now, due to the COVID pandemic, the most part of pharmaceutical companies switched to decentralized clinical trials with telephone communication. And you know, it's okay. It's not a problem at all. You need just to provide this blinding, you need to provide endpoint continuity and all these procedures. And so you can use telephone contacts.
Блин, обалдеть, почему не отключаешься?
Just a moment. As for, I'm sorry. As for subjective endpoints, yes, I'm a huge fan of subjective endpoints actually, because it's a trend to patient-oriented endpoints. And what we consider clinically significant is not a deal of a patient at all. And the patient doesn't want to have a lower glucose level. He doesn't want to have higher thrombocyte level. He just wants to feel better. And actually, the regulatory requirements tell us about all these quality of life studies, and all the quality of life questionnaires are highly subjective. But I think that these patient-oriented endpoints are much more important than our clinically objective endpoints, because our trials and our medicine is for patients, not patients for the trials. And that's why sometimes it's difficult to provide the high quality, but if you can, it's much better than using non-meaningfully objective points.
Yeah, thank you. I just also want to mention it was interesting discussion yesterday. I was on conference and it was talk about discovering new treatment for opioid use disorder. And the point, one person shared this information that they say that FDA, the Food and Drug Administration, the company, which, the government organization which support or not approved or not approved treatment, they actually looking only for quantitative outcomes. They actually don't like qualitative ones, and everything about like quality of life, especially when we talk about like opioid use disorder, it's so hard to actually convince the people like on regulatory. Right.
Yes, it depends on the regulator, and actually I'm mostly in topic of diabetes, and they still ask for glycated hemoglobin, and it's totally nonsense endpoint for a patient and even for treatment. Since we have these continuous glucose monitoring systems, we understand that perfect glycated hemoglobin could be in very poor controlled patients. And I speak against this endpoint for many years already, but nothing changes. I think that they need a lot of time to change, because all these regulatory requirements are highly
bureaucratic.
not bureaucratic, but they don't like changes. It's so difficult to change anything there.
Actually, no one likes changes.
So I think that we should be the people who will move the world and who will move these changes.
Totally support
Well, and please, I ask you, I beg you, never use the visual analogous scale during a by phone interview. Never. All these scales, they must be evaluated only at the visit, when you see the patient and when you give the patient a paper where the scale is printed. And this scale must be printed on the same printing machine. And it doesn't matter if it was broken, because if the printing machine was broken, you have invalid data, because your scales could have different lengths, and you must count these millimeters from the left to the cross, for example, that patient put. And if the paper is another kind, if the size of this line is another, so you will have different results from these questionnaires. And when you call a patient and tell him, just tell me the number from 0 to 10, how do you evaluate your feelings? He will not tell you appropriate value. These scales should not have any numbers at all. It's just a line with no other numbers on this line. And it's a beautiful instrument to evaluate these patient-oriented outcomes and feelings. And it is used in EACO 5D, for example, the quality of life questionnaire, but it should be used appropriately. And when I gave this scale to the patients, I noticed that the most of them can't understand it. So you cannot just give a piece of paper and go away. You need to explain it, and if it's a patient of the older age, if a patient has some other mental disorders, it's really very difficult to explain how to use the scale, because patients don't used to it. So I like this instrument, but it's difficult to be used.
May I have a question? Because it's a little bit contradict with my action right now, because we also influenced by COVID, and for example, in some of our trials we do telephone interview, and we don't change our assessment, and we couldn't just so. And the question is, what is better? Just don't do assessment when you evaluate something by visual analog scale, or actually try to say person, okay, imagine, and they give you the number, of course, because like you said, okay, give me some number, and they give it to you, and it's probably not valid, but it's better than nothing. So you have only like two options, so you couldn't provide like in-person visits. So
Yes,
what
I don't like losing data, and that's why I think it's better to have any data you can get. But when you analyze this data, analyze it all together, and then move away all this data that was got in an inappropriate way, and just compare the results. If the results change a lot, so it's invalid data. If results are almost the same, so it's okay. But when you write the article, write about it in limitations of the study, that this number of patients at visit 6 and visit 7, for example, they answered on the phone, and then it was okay. Because COVID will end, and you will get the data later, and there are some ways to insert any data if it was lost, and there are plenty of these ways. So you'd better collect this data and then to make sensitivity analysis.
So that's why I think you should change your slide and say not never, but sometimes. In most of the case, please use.
Yes, you know, during COVID, we did so many things that we told that we would never do.
Yeah.
But so we had to. Well, what we compare, I want to return to the goals. The first goal, is acupuncture more effective than usual medical care alone? Do you see my mouse here?
Yes.
Well, they compare, for this goal, they compare the first three groups all together with usual care. Then for the second goal, is real acupuncture more effective than simulated acupuncture? They compared both types of real acupuncture with the simulated one. And for the third goal, they compared just these three groups, the two groups of individualized and standardized. I've read the statistical part several times. I couldn't find the adjustment for multiple comparisons. It's my pain, because probably it was the old article. I don't know. But in Russia, still, I don't see this adjustment for multiple comparisons, but it's really important, because when you compare plenty of groups, and when you test plenty of hypotheses, it's just a game of chance when you get what you want. And to avoid this situation of false positive results, you need to do this adjustment for multiple comparisons. Again, there are plenty of methods of doing that. You can just type it, and the first article in Wikipedia provides you several types with a good explanation. But please try to do this, not all the time, but if you say that I will make a decision based on these results, then use it. If you are not going to make any decisions, and you say that this trial was like a search trial, just to test any hypothesis, to choose one to test it appropriately, then you might not to use adjustment for multiple comparisons. So if you make recommendations, it's a strict rule. If you don't make any recommendations, you might drop it.
I actually find out that on table 3 they make a comment that they actually do adjustment for multiple comparisons.
Oh, that's great. Probably I need to sleep more to read more attentively. But
No,
it was
anyway.
difficult to find it. It should be described in statistical part. So when the endpoint is multiple, when you have two clinical endpoints, for example, decrease in pain and increase in ability to take care. And the statistics here is different, depends on if you want to show both of these endpoints or only one of them. I will not tell a lot about statistics. If you need, you just can search it somewhere on the internet. But remember, if you have two conclusions, you need to think if you need an adjustment for multiple comparisons. No need to make it all the time, but to think about it is very important. And the second multiple endpoint type is when you assess the endpoint in two time intervals. For example, if you say that your endpoint is decrease in pain at week 8 and at week 12, it's not one endpoint, it's two endpoints. And it's very often forgotten. You can use here either multiple comparisons adjustment or ANOVA analysis. I also will not get into details, just not to speak about this very difficult statistical stuff. But still, there are several ways to solve the problem. Well, and the last slide about statistical analysis, it's the phrase from the article. They told that they adjusted the data for the baseline measure. It's very common, it's okay. Then they adjusted for site, for clinical center, it's called site, for age of a patient and for the sex of a patient. I don't understand why they needed to adjust for age and for sex. But instead of site, I would advise to adjust for the therapist, because the therapists, acupuncture therapists, they have very different experience and they influence on a patient differently. And there were not much of them. There were not about 500 of therapists, so they really could adjust it for it. And I would also adjust for previous experience of acupuncture, if it wasn't mentioned in criteria for inclusion. And I would adjust for need for other treatment of pain, because I also couldn't find the information if the patients could get any drugs to stop the pain during this year. I suppose that they could. And it's important for how many times during the year they needed it and for how long they needed it. I mean, some patients could take it 10 days a year and some just 100 days a year, and it's very different in terms of our endpoints.
I just want to make one small comment about therapists. I am not really sure that one patient was always on one therapist. So I don't
in this case, yes.
Yeah. Oh, okay.
Yes, if they had different therapists, so no need to adjust for therapists.
Yeah. I mean, they don't talk about this, right? So they
Yes.
don't make it clear, like, is it...
I couldn't understand that.
Yeah. I mean, like, this is like, it should be on details, like, confidential.
Yes. Are there any other questions about methods of the article? Because I will move to results. Well, as for results, I just show you this table and I don't like it. Because in this table, we see the absolute values. We see the absolute values at each week in different groups and for both endpoints. But these absolute values tells me nothing. I want to see the values compared to baseline for how much the patient improved. And I couldn't, I spent a lot of time trying to understand what are these p-values. And after all, I decided that it's a comparison between these values. Actually, it makes no sense because we are interested only in comparison of changes from baselines. It is very...
Sorry. I actually think that it's comparison between baseline and 8 weeks. But what about, yeah.
I couldn't decide it, really. I read the article several times and
Yeah.
I'm still not sure.
Yeah, like visit or intervention, right? Like.
Yes, here totally, absolutely, here should be the values of for comparison of changes from baseline, because it's no need to compare absolute values regardless of the baselines. So I don't like this table, but still you can see something from this, but it should be presented in another way.
Can you give us some sense like how you make this table? If you want to make it.
Well, here the baseline is okay. It should be like this, and this mean and standard deviation is quite okay. It's very important to state if it is a standard deviation or standard error, because it's very important for understanding the results. And here I would like to see something like minus 4.4, minus 4.5, and so on. And everywhere here, I would like to see these values.
So you mean like difference between baseline
yes,
and follow-up?
Only difference, because I'm really not interested in the absolute value. And it's just, I don't know, it's not a lie, but it's something like a dust into ice. And some marketing people, they can use it in case the differences are not interesting, but here it's really very interesting. And don't be caught by this. Always evaluate the changes, because the baseline, it is almost equal because of the randomization, but it could be different, and it's okay if it is different. And the changes, they will show you the real picture. They showed the changes on the plot. It's a good picture, but I would expect to see here p-values for these changes. I mean, it should be here and here and here, and on the second plot the same. Probably it was in the text, and actually it was in the text, but people don't like reading texts. People like looking at the picture, looking at the table, and close your article. So everything important must be in the abstract and on your illustrative material. They will not spend half an hour to find p-values. Do you have any comments or questions regarding results? Well, then I will also comment on interpretation of results. I really like this interpretation. It's it looks trustfully, and it's really good. So the first question, is acupuncture more effective than usual medical care alone? Here are the quotes from the article. Compared with usual care, individualized acupuncture, standardized acupuncture, and simulated acupuncture had beneficial altogether and persistent effects on chronic back pain. Yes, I agree. But no but. It's okay. So it was effective altogether. It was consistent altogether. The second, is real acupuncture more effective than simulative acupuncture? The authors say that one German trial found that both real and sham acupuncture had similar effects. A second trial found that both real and sham acupuncture were not significantly different from each other. It's the same, so they didn't differ. And our trial extends the findings, so they prove these findings again. There is no difference between real acupuncture and sham acupuncture. And they didn't comment. The third question is not okay, but they just missed it. I don't know why. But you can see you can see the answer from the plots. It's not any difference between individualized and standardized one. And I can see that it shows that patients were completely blinded. And here, it's a very good case to speak about a placebo and nocebo effect. Placebo effect is very popular. Also say that collectively, these recent trials provide strong and consistent evidence that real acupuncture is no more effective than various forms of sham acupuncture. However, both of them are superior to usual care. So I will translate it to the human language. Any acupuncture-like intervention causes placebo effect. It's okay. It's quite okay if a patient has any type of intervention that helps him to feel better. The authors provide two possible explanation. The first is probably you remember these the zones of Zacharnik get. It's superficial point stimulation stimulates some processes that lead to improved pain and function. Maybe. I don't know, because we cannot say, I really don't like to say that the drug is ineffective. I prefer saying that we couldn't prove the efficacy of the drug, because maybe we couldn't give the sensitive endpoint. Maybe we couldn't provide the perfect design to demonstrate the efficacy. But still, they also say the same. They say that we couldn't show the efficacy. They didn't say that it's ineffective. And the second possible explanation is the placebo effect, that patients improved functioning because of therapist conviction, patient enthusiasm, and receiving a treatment belief to be helpful. It's a discussable question if we should give these placebo interventions. And the authors also provide some information about that. They counted the costs of treatment, and the cost was really high for acupuncture. So probably it's a too high placebo, but too costly placebo. But if the cost is not high, so just think about it. I will not. I have not a special. I don't know. I'm not convinced on this topic, and you need just think about it. What is better, not to give anything, or to give a placebo that makes a person feel better? And now I speak about all these elderly patients who just ask you to make an intramuscular injection or intravenous injection, and they think that you don't treat them if you just give them tablets. It's all about this. So when placebo effect is a problem for demonstrating efficacy in all psychoactive drugs, in all emotional distress, in all psychosomatic symptoms, especially anxiety and depression, in all populations seeking for physicians' attention, and it's true for Russian population, our patients in our trials, they improve a lot just because they come to the visits and the physicians examine them and they speak a lot, they explain a lot, and we have a huge placebo effect in all our trials, in any condition, for subjective endpoints. And it's also the problem in children. I don't know why. They say that the younger the child, the higher placebo effect is, and that's why antidepressants, effective antidepressants, cannot demonstrate effect in small children. Actually, I don't know if small children can have depression, but it's for Marina probably to comment on this.
I'm not specialized in childhood psychiatry, but from my knowledge, they have affective disorders, but I don't really think that they have like big, like major depressive episode as they do in adults. But of course, like there are like child and adolescent psychiatry, which is like very superficial field for me.
I know that there are a lot of pediatric trials that are failed, not because of the trial or because of the drug inefficiency, but because of this placebo effect in children. I think that children believe their parents. I don't know.
Yeah.
And parents say that you are treated, they need to put a lot of effort to make the child to take the pill. And, they give a lot of this placebo effect to their children. I don't know. Actually, I don't have experience in pediatric clinical trials, but still. And as for nocebo effect, it's not so popular, but it also exists. For the same categories: psychoactive drugs, emotional distress, psychosomatic symptoms, and pain. Pain is the perfect example of nocebo effect when patients were told that it's a saline injected to them, and they felt the pain as the same as it was even when they got morphine. It's highly mind-dependent state. And we also know about nocebo effect in generic and biosimilar drugs. If the trials are open label, and they are usually open label because most of the, for example, biological drugs are injectable, and it's impossible to mask injectable drug. And there are plenty of publications from the USA, from Europe, that patients who knew that they get generic or biosimilar, they drop treatment more often, and they had worse compliance. And they evaluated subjective endpoints worse than those who got original drug. Whereas as for objective endpoints, there were no any difference at all. And it is seen in any clinical sphere. It is seen in rheumatoid arthritis, in psoriasis, in diabetes, in everything. It's just our beliefs, again, not only patients' beliefs, but physicians' beliefs. And it's a huge problem of all the generic and biosimilar drugs. And when I was a student, I've heard plenty of times that generics don't work. It doesn't work like that. Generics are the same as original drugs because there is a huge dossier on the drug that is studied very attentively by regulatory organs. And in case there are any real difference, the drug would never be approved. But again, this nocebo effect is very strong, and I saw it in clinics when I worked as endocrinologist for levothyroxine. There were patients taking 150 micrograms of levothyroxine. It's almost the highest possible dose, and they had no effect. Even they had no effect on the feelings, on the I don't know, the perception of symptoms, but the blood analysis, like tiotropic hormone and T4, they were almost okay. So these placebo and nocebo effects are described in details. For example, I can advise you to read this scientific popular book of Piotr Talantov, P less than 0.05. It's a good book. It's a good book of history of medicine from the point of scientific medicine. But Piotr is maybe too aggressive sometimes. He is just about black and white, but as I understood, he has always been like that. But still, the book is really nice, and I can recommend it to you. So I have finished here, and we will discuss any other question now. I just want to tell you, to remind you my phone number again, if you have any questions on what I've said, or probably about planning of clinical trials, or maybe, I don't know, career in pharmaceutical company. you can write me here. And I also have almost that Instagram profile. It's yes, it's trials room. Yeah, you can go there, and if you send me any questions, it would be more alive. Because actually, I don't know what is interesting for people who doesn't work in this field, who don't work in this field, for scientists, for students, for PhD students. So if you ask me anything, I can write on any post.
Yeah, that's great. Thank you so much. Okay, there are time for, we're actually a little bit out of time, but if anyone have any question, please, this is your chance. Anna, thank you a lot for this incredible presentation of the paper, and very interesting. And someone have something to say, or I can ask questions. Okay, I think no one. So probably this is one thing about the paper, which I would like to say. Usually when I look on clinical trials, and this is probably what I'm interested in, and asking for you, how you deal with it. This is the measure pain for me is follow-up, and the participation rate over time usually is dropped. And here we see very high participation rate. It's about like 90% or more, especially in acupuncture group, which is also kind of reflect the placebo effect, and the people go to visits just because they think that it helps them. So, and they less go. So, for example, it's on the paper. So, what do you think? Like, do you actually believe these numbers? Is it possible? Like 97%, like okay, like 94% 1 year observation.
I believe these numbers, especially because it's a Chinese population. Because there might be differences in populations, and Chinese tend to follow the rules. They tend to, I don't know, to respect their doctors. And actually, there are different ways to improve the follow-up. We also have this problem with follow-up all the time. But we can encourage the follow-up by encouraging doctors, so they will have some benefits if the patient completes the studies, and then it's a problem of a doctor to inspire the patient to return. But actually, we usually add some diagnostic procedures that are interesting to patients, so they will be really interested in coming again. And we usually add a lot of phone contacts. It should be at least one phone contact every month, because if you drop the patient for more than 1 month, the patient will drop you.
Yeah.
But as for Chinese population, yes, I believe we usually have rather low dropout level. It's a huge work of our team and of physicians working with us, but it's possible.
Thank you. And one other, like, this is final thing. Like, we are trying to make this journal club like for students, for future medical doctors who will be encouraged to read scientific articles, like original research, and make something different in their clinical practice. Like, and for example, this, like, based on conclusion and results which you see here, you probably may have may come to conclusion that, okay, like, looks like acupuncture is working, and should I actually prescribe and recommend acupuncture because it's worked better than usual, evidence-based care. And we actually have a paper with nice design and with statistical and graphs and very fancy presentation of results. Like, what I think this is very interesting article, just to thinking about how results can be actually interpreted in clinical practice, like how you I don't know, like what is like my question for you, but probably can you give us a little bit like your feedback on how you, like after reading this research, like what do you do in your clinical practice? Do you do something differently or not?
As for me, I would make a conclusion that acupuncture itself doesn't work, but something acupuncture-like can work for patient, and it's my attitude to all to all drugs with not established effect. If a patient really wants it, if a patient asks for it, for me it's okay to give him the drug, because our patients, they don't live in era of I don't know, in era of all these clinical trials. They need something, just doctor, do something with me. And if you do nothing, you're a bad doctor. So it really depends on a patient. I had not so big experience of clinical practice, but I had different patients. Some of them asked for proofs. Some of them read a lot of articles, even in PubMed. And of course, they will not believe in acupuncture in this case, and they will not do it, and you don't need to provide it to them. But some patients believe in, I don't know, in a beetroot eating for lowering their sugar, and they really asked for something. They complained that we didn't give them alpha lipoic acid for pain relief, and they believed that they feel this awful pain because we don't give them alpha lipoic acid instead of there is no evidence of its efficacy.
Yeah.
So I think it's better to give them if you can. It's a very difficult question, and I think that every doctor should solve it himself.
Yeah, and I also think it's, you know, it's very important also for like insurance company. For example, if you have acupuncture in your insurance, and actually doctor don't prescribe you acupuncture with which actually someone pay for this, because doctor is evidence-based and don't believe.
Yes,
So,
there are a lot of stakeholders, not only evidence-based medicine. There is money, there is psychology, there is all this stuff.
Yeah. Okay, this is super interesting. Maybe someone would like to ask something about anything related to evidence-based medicine or pharmacology or acupuncture or career in pharmaceutical company. So you have cell phone, you have Instagram, email maybe. Someone have trouble with microphone. So Anna, did you see this group chat? I can read for you.
Yes, I see. I'm reading right now.
Uh-huh.
Yes, you got absolutely right. The nocebo effect is usually described as adverse reactions from the patient list of the drug. But also, as I told about pain, it includes the complete absence of the drug effect. The pain is the better example. In other fields, you can see something not so strong, like in pain trials, but it also has.
Okay. Okay. Marina got your answer. Great. Thank you so much for participating in our journal club. Anya, wait you on Instagram, please. It's really amazing. Just spend I don't know, half of your day reading through this Instagram account, but like for learning more about clinical trials, it's really inspirational. And don't forget to complete our short survey after this meeting. And thank you all for spend time today and this evening, and have a good evening. Thank you. Oh, by the way, I record this video and you also